Hello, good morning. So we have to wait few more people like Kerala, Irina M, Sardiok, Artem, Urin, and Anabur. So we have to wait or we have to start. Okay, so let's start. So today we have a presentation. Okay, so let's start. Today's we have three presentation, and I also share with you the names of these presentation in the chat box, and I also share with you the link for the training feedback. So kindly copy this training feedback link and give your feedback before the deadline. So it's an important point, right? So let's start with today's presentation on the torch. As you know that the torch is basically a profile idea. It's used for to rule out the congenital anomalies and the birth defects. And these are due to the protozoans, viruses, and bacteria infections like toxoplasmosis, rubella, cytomegalovirus, and herpes. These are the causative agent for having neural tube disorders, some congenital anomalies, and some other issue with the fetus during the pregnancy. So let's discuss about the torch. So in this torch, we have three major parts in this presentation. The first part is about the background of the torch profile and what is torch and what is the clinical utilization and then application of that the torch profile and what are the solutions which are provided by the SNI from the Meglumi platform. So let's start with the background. What is torch? As you know that in a torch, if we goes to So, if we talk about the TORCH, basically TORCH is the acronym for the group of infectious diseases that cause the illness in the pregnant woman. And usually at the birth, during the birth, it can produce a defect in the newborn babies. And these panels is a group of blood testing, serological testing, which shows the presence of the antibodies, which is produced by the immune systems against that infection or which infections are considered to be screened during the pregnancies. These are the Toxoplasma gonadei, others rubella virus, cytomegalovirus, and herpes simplex virus. So, what about the others? The others agents, which include other Coxsackie virus, syphilis, varicella zoster virus, HIV, and parovirus B19. So these are comes under the TORCH profile of others parameters or other screening assays that need to be complete the TORCH profile in a pregnant woman. So, if we talk about the clinical utilization of or the manifestation of the torch infections, you know that the torch testing algorithm is in obstetrics and the neonatology. That's what is the clinical presentation. So, what are the clinical symptoms when you go for a torch profile? The first clinical presentation is a pregnant woman if exposed to or at a risk of the torch infection. The screening should be done for that pregnant woman. The second clinical presentation is the previously well pregnant woman with the symptoms of torch infection if she has in the past some symptoms of the torch infection, history of the torch infection. They can go for the screening test for the torch. If they have previously well pregnant women with the fetal abnormalities detected on routine ultrasound, so they are also comes under the clinical utilization of these stores profile. The fourth is part is the finding in the neonate suggestive of the congenital infection identified after the birth. So the last clinical presentation is the unexplained intrauterine death or a stillbirth. Also leads to go for a next pregnancy. Pregnant woman goes for a torch profile. So if a developing fetus has a positive history of a torch profile, then the outcome of pregnancy may leads to some the miscarriages, some stillbirth, or a fetal growth abnormalities and the maturation issues in the during the intrauterine growth, retardation, or in some cases, is an early delivery has been indicated when the fetus is infected by the torch infection. So it is very much important to create awareness among the pregnant women or the women who are childbearing age to show the importance of the preventing the torch profile. So let's talk about the part two, that's in the clinical application. So we have to discuss one by one the viruses, bacteria, and the protozoans. Let's talk about the toxo infection. So you know that the toxo is basically protozoan parasites that infect warm-blooded animals and a human. So you can see the transmission of the toxo from the warm-blooded animals to them, and then through the soil and surface water contamination that's going to the food, and then it's going to cause the contamination to the human as well. So for the pregnant woman, is very much risk factor for the case of the toxo infection. If they have infections, then the source of toxo infection is only from the foodborne and environmental contamination. If we talk about the toxoplasma gonadei structures, you can see that this structures it contains the endoplasmic reticulum, the plasma membrane around the nucleus, and the inner membrane that's in micronutrients and dense granules with the conoids that's an growth factors which help them to grow. They have a microtubules and apicoplast and mitochondria and nucleus, which all the features of proteins are there, and they are pathogenic in nature. So if we talk about the epidemiological distribution of toxo um, uh, toxoplasma IgG and IgM, then you have to go for a toxo approximately infected around one third of the human population worldwide. If you see the global epidemiological seroconversion prevalence type of toxo group on the basis of the color coding, you can see that if the maroon colors means the greater than 60% population having infected with the toxo infection. So those countries, like you can see here in this area, the Brazil, Argentina, and then Peru countries, the countries are impacted with more with the toxo infections, and the countries which have a less prevalence, you can see here the China has a less prevalence, and about the Russia, the Mongolia, Kazakhstan, and then the Afghanistan, these countries, and Pakistan, these countries, data is not so clear. But if we talk about the prevalence of toxo between 40 to 60% in the countries, especially if you talk about here that the Iraq, Turkey, Jordan, and the Egypt, and these countries like Ukraine, Poland, Germany, Rome, and some part of the France, they have also a 20 to 40% of prevalence of toxo infection in their population. So if we talk about more about the symptoms of toxo infection, you can see here that the healthy people, which includes the non-pregnant women as well, they have a flu-like symptoms. Maybe they have some tender lymph nodes and they have a muscle X during this infection of toxo infections. When the mother to childbearing age, that's called a congenital disorder. That may leads to the congenital disorder. They have a miscarriage, stillborn child or child born with the abnormal enlargement and the smallness of the head. So these are the typical clinical symptoms of the fetus, which gives an evidence that these baby was during the pregnancy was maybe infected with the toxo infections. So, if we talk about the serological testing for toxoplasma antibodies testing, there are two types of antibodies testing like IgG and IgM. You know that the IgM is produced when during the first week of the infection and reach at a plateau with the 1 month. So, if we go for IgM value, you can see that this IgM value goes up, and with the 1 month they goes into the peak level or the plateau of that IgM value of toxoplasma. So if we talk about the IgG, then you can see that the IgG reaches a plateau with the second or third month, and then decrease more or less rapidly, persists lifelong as a residual titer. So that's markers that helps to check the current status of exposure of the woman, pregnant woman, and the fetus to the toxoplasma virus protozoans. So if we talk about the toxo IgG antibodies, is productive. Once recovered from the toxo infection, the people can acquire the immunity. So if they have a start to perform toxo IgM and IgG test, then there are four possibilities. Maybe the IgG negative, IgM negative. It means there is no immunity in that patient, or avoid primary infection, repeat testing during pregnancy, and then start. So if the pregnant woman for the screening purpose goes for this serological testing of toxo IgG and IgM, then they have to go. They have got the results of IgG positive and IgM negative. It means they have acquired immunity. They have a past infection likely. Now there's no need to go for a further investigation. That since status is stopped. So if they have IgG negative and IgM positive, and in second case, IgG and IgM both are positive, these are the two typical cases in which they have to take some action like that's if IgG is negative and IgM is positive, it's an unclear indication of the beginning of the infection, or maybe unspecified IgM is there. So you have to repeat testing 3 weeks later. And then after 3 weeks later, that's again it's a positive. Then you have to go for a consultation with the obstetrics and gynae physician for the rule out of neural tube disorder or fetal anomalies. So if they have IgG and IgM positive, then they have to go for a toxo IgG avidity testing. In this case, there are two possibility: either the intermediate or low toxo IgG avidity test. Then you have to repeat IgG test after 3 weeks later. Then you have to check the toxo IgG titer. If it is stable infection greater than 2 months before the first samples, then further action may be required. But if the IgG titer increasing 2 to 4x fold increase, then the recent infection less than 2 months before the first samples, then the further action may be required. So in this typical case, you have to refer to the physician or a gynecologist who will take appropriate action according to the condition or the other radiological imaging feedback for the pregnant woman. So this is the serological testing algorithm for the toxo IgG and IgM and the further investigation procedures. If we talk about the rubella virus, so basically the rubella virus is a pathogen agent of the disease rubella, and is the main cause of congenital rubella syndrome when infected occurs during the first week of the pregnancy. So you can see the structure of that rubella virus. It's the non-structural and structural part. The structure part contains the glycoprotein that's in the E1 and the E2, and the lipid bilateral membrane with an isosaccharidyl nucleocapsids inside the nucleus, which is an RNA-based virus. So rubella infection in the pregnant woman may cause the fetal death and the congenital defect known as CRS. So the rubella virus is transmitted by the airborne droplet when the infected people sneeze or the cough, and the humans are the only known host for the rubella virus. So according to the data, this transmission electron microscope of the rubella virus, there's an estimated that 110,000 babies are born with the congenital rubella syndromes every year. So if we go for a global distribution, for the rubella virus, you can see here there is no specific treatment for the rubella, but the disease is preventable by the vaccination. So in some countries, have a vaccine in the national immunization program in 2019. They have planned introductions in 2019. They have to give 170 countries, approximate 80% of the world are vaccinated, and they have a rubella vaccine for preventing the infection with the rubella virus. So you can see that the countries like here, so many countries have a green in color. They have introduced the partial introduction to date of the national immunization program. Even in Pakistan, we have a immunization program, but it shows here not available, no introduced, no plan, or no data, which is 11% of the world. But we have a rubella vaccine program from birth till 11 years of age. We are also have a national immunization program for these diseases. So you can see here, if we talk about more about the symptoms of rubella virus, you can see that the children have a rash, they have a low fevers, they have a nausea and mild conjunctivitis symptoms with the swollen lymph node and behind the ears and in the neck. So this rash first appears in the neck and the face, and then scattered rash on the body. So these are the typical symptoms of the rubella virus infection. In the male, it's cause an arthritis and painful joint that usually lasts for 3 to 10 days. So if you talk about the pregnant woman, they have a stillbirth, spontaneous abortion, and congenital rubella syndromes. And these are the major cause of that's the congenital disorder due to this rubella infection. So if we compare the pregnancy days and week, would compare the risk of infection or the affecting risk that if between the 0 to 28 days of pregnancy, there's a 43% chance that infant will be affected. So if the 0 to 12 weeks, then a 51% chance the infant will be affected. If after the 13 to 26, there's 23% chance the infant will be affected by the disease, or 26 to 40-week infants are not generally affected if the rubella is contacted during the third trimester. So the first trimesters and the second trimesters are clinically more important to monitor the CMV virus infection and their typical symptoms in the woman. If they are during the pregnancy, they have infection from first week from first trimester in between the second trimester. They have a typical symptoms of severe headache. They have some cases the vomiting. They have a sore throat. They have a skin rash, the multiple organ inflammation, and the muscles pain and joint pains are one of the examples of these symptoms during the pregnancy. So if we go for a serological testing for the rubella antibodies, and you know that there are two antibodies like IgG and IgM, they need to be checked during the first and second trimester of pregnant women. So the IgM detect a few days after the infection, and the peak level is 7 to 10 days. You can see that the peak level comes with the 7 to 10 days. Here you can see that with the IgM, and then they disappear in the 4 to 5 weeks. So after the infection of 4 to 6 weeks, they are disappeared usually, but the IgG level rise with nearly 7 to 21 days and remains for life. So the early marker for the exposure of rubella is IgG. You have to go for IgG. If the IgG is positive, then they have to go for IgM test as well for if they want to rule out the current infection is not there. So according to the Center for Disease Control and Prevention and the Manual for the Surveillance of the Vaccine Preventable Diseases, they have algorithm for the serological evaluation of the pregnant women that are exposed to the rubella. So if the IgM and IgG at the time of first visit has gone for the screening test is a test that like the IgM and IgE, if the both are positive, they have to go for interpretation is acute infection or a false IgM positive, maybe that. If the IgM is positive and IgG is negative, so it's a rare case, but it's need to be verified after sometimes. So collect the second serum samples 5 to 10 days later. IgM and Ig and avidity testing to be conducted. If the high avidity, no rise in IgG titer, testing together with the first serum, that likely false positive. If low avidity, rise in IgG titer, testing together with the first sample, acute infection, and then discuss option for the pregnancy outcome. So if the IgM is negative and IgG is negative, both are negative, then the patient is susceptible to the infection. Then you have to repeat IgM and IgG after 3 to 4 weeks from the suspected exposure test accordingly with the current specimen. If after 3 to 4 weeks IgM and IgG is positive, then the acute infection, then go for a discussion for option for the pregnancy outcome. If again the IgG and IgGM for the rubella are negative, then repeat IgM and IgG in the 6 week if the risk of exposure continue to exist, and then go for a positive. If you have a positive, then consider as an acute infection. If again the negative, then an infection discarded. So if the rubella suspected or some clinical history of the pregnant woman is there, so they can check at the initial pregnancy in the first trimester or early weeks, and then in the 3 to 4 weeks, and then in the 6 weeks. So after the 6 weeks, they have to go for rule out that the infection has been discarded. So if we talk about the serological testing of rubella antibodies and interpretation, if the person is adult or the child, IgM is positive and IgG is positive or maybe a negative, it's a recent infection. If adult or child is IgM is negative and IgG is positive, it shows the prior infection or vaccination immune. So again, in this case, if the Ig is positive, it may you have to ask to the patient about the vaccination history if they have a vaccinated. So this immunity is developed due to this vaccination. If we talk about the newborns, if they are newborn, IgM is positive, that's a congenital infection. If the newborn IgM is negative and IgG is positive, this is the maternal immunity, passive immunity from for up to the 6 month is expected when the fetus has got a IgG positive rather than the IgM. So about 10 to 20% of the newborn infected in the utero fail to survive past the 5 years of the life. And the rubella IgG antibodies is protective. And once recover from the rubella infection, people are immune to the rubella virus. So either on the exposure of the rubella virus is important or a vaccination is important. In both cases, they will develop, even the pregnant woman can develop IgG values. So it's better to have IgG positive and IgM negative during the pregnancy. So the next is the cytomegalovirus. It's basically a common virus, yes, you know that, and it's once infected, your body retain the virus for the life. So this cytomegalovirus is spread from person to the body fluid, like blood, saliva, urine, semen, and breast milk. There's no cure, but there are medication that can help treat the symptoms. So the microscopic morphology of cytomegalovirus, you can see that there is an owl eye, and they have a SCMV, human cytomegalovirus. You can see that the virus is the viral capsid and the glycoprotein and the tegument and the double-stranded DNA and the membrane around that. So this is the structure of that virus. And according to the epidemiological distribution of the cytomegalovirus, you can see here in a survey that CMV zero prevalence in 83% of the in the global general population, and around 86% in the woman of the childbearing age, and 86% in the donor of the blood or organs exist. So if we see the CMV seroprevalence, if in the countries where have 0 to 9.1, you can see that shows in the maroon colors. These countries are the examples is the Brazil, like Chile, and the countries like China, they have other countries close to that, the Turkey, and then the Middle East countries, and in the African countries like Tanzania, Uganda, Rwanda, and the other countries. In here is and African countries like Nigeria, Mali, Ghana. So these are the countries which are having estimated zero prevalence in the woman for the during their reproductive age. So, if we talk about the CMV infection, so the people at a greater risk of signs and symptoms with the CMV includes the newborn infected with the CMV virus before the birth, that's the congenital cytomegalovirus, and the infant who have become infected during the birth or shortly afterward, the perinatal cytomegalovirus. This includes babies infected through the breast milk. So the people with the weakened immune systems, for example, due to the organ transplant or HIV infection, they may have a symptoms of premature birth and the low birth weight, yellow skin and eye. They have enlarged and poor functioning liver, the purple skin spots or a rash or both. Abnormal small head, that's called a microencephaly. Then an enlarged spleen and the pneumonia and the seizures. These are the symptoms of the cytomegalovirus infection. And then, if we want to go for a serological testing for the cytomegalovirus, we have a two options: CMV, IgM, and IgG. You know that the IgM is detectable in the acute infection, while the IgG slowly rise to a high level and remain for the longer time. So they have a typical the status of the vaccine status, and then the past exposure status can be differentiated with the IgM and IgG values. So in the acute phase, the first is that the CMV IgG is raised and the peak value or plateau is achieved during the acute infection. In the convalescent phase, you can see that that goes to the lower level, and then it's again go to a reactivation of IgM in the reactivation phase, while you can see that the IgG is raised in the middle of the acute infection and then gradually raised, and it remains the stable during the convalescent and the reactivation phase. So even if the people have been infected in the past, there is still a risk of reactivation is there. So it's more important when they have infection of CMV history in the past, so they have to be more careful about that. So, according to the Society of Obstetricians and the Gynecology of Canada, they have at least 8 weeks after presumed infection, and the cytomegalovirus is defined as a cytomegalovirus PCR, amniotic fluid, or a PCR of newborn urine, blood, or saliva. So, if we talk about here the maternal CMV serological testing for the screening, if they have a CMV IgM is positive, CMV IgG is negative, then they have to repeat CMV serological test in 3 to 4 weeks. After 3 to 4 weeks, there are two possibilities. Either the CMV IgM is positive and CMV IgG is negative, or second option is the CMV IgM is positive and IgG is also positive. So if IgM is again positive and IgE is negative, there is no specific follow-up. There is a possibility of false positive IgM value. Maybe then no further investigation is required. But if they have IgM is positive after 3 to 4 weeks, and then the IgG is also positive, that's confirmed the zero conversion time, and then this is the window period, early detection in the first stage, and then you have to go for a recent CMV primary infection, which is less than 4 months. So the further investigation, like the ultrasound, amniocentesis for the CMV PCR, or amniotic fluid PCR for the CMV virus, and the newborn testing for the CMV testing. So if you talk about the CMV IgM positive or indeterminate, or CMV IgG positive. So in this cases, they have a IgG avidity testing. If the IgG is low, then avidity go to the recent CMV primary infection. If the IgG avidity is high, then the remote CMV primary infection is greater than 4 months. Normal ultrasound, no specific follow-up, but abnormal ultrasound, and the sign of CCMV infection seen, then the consider alternate diagnosis Then test is stored as samples if available. Aminocytosis for the CMV, PCR, and other etiology is required. So the newborn testing for the CCMV is required. So the last algorithm is the CMV IgM is negative, but CMV IgG is positive. Then they have to remote CMV primary infection is more than 4 months, or the clinical history of the patient is required, or a pregnant woman is required, either they are vaccinated. So if you talk about the HSV infection, you know that in the HSV, it's basically a large envelope uh, isohedral virus, and this only a natural host is a human. So the herpes simplex virus are of two types. One is called HSV1, the other is called HSV2. These two viruses are structurally and morphologically similar. Because of the personal privacy and social prejudice, most persons infected with the genital HSV have not been diagnosed. So if we talk about the structure of this herpes simplex virus, it's a DNA-based virus which contains the capsids around that, the supporter of the DNA, and they have a nucleocapsids and the teguments and the envelopes and then the glycoprotein to protect the DNA of that herpes simplex virus. So the 50 to 90% of adult carrying the herpes here and 27% of adult carrying herpes here. So there are two types of herpes, HSV1 and the HSV2. So if we talk about the HSV, including one and two, the global estimation of the numbers of people with the prevalent of HSV2 infection in 2012 has an between or different age and sex in the region. You can see that the area is European, African countries like having a more exposure of 134.9 million people are infected with that. If we talk about the other countries, like China and the Australian region have 81.2% million people are infected with that HSV virus. If we talk about the other countries like the North America and South America, 30.3 million people are infected with the HSV infection. Along with that, in the Russian region and the European region, there is a 31.4 million people are infected with the herpes simplex virus type 2. So we have to discuss about the HSV1 and 2. So if we talk about the HSV1, is basically mainly transmitted by the oral to oral contact to cause an oral herpes, which includes a symptom known as cold sore. So these are the typical symptoms of HSV1, but can also be caused a genital herpes as well, right? So any estimated and estimated that the 3.7 billion people under age 50, that's a 67% have HSV1 infection globally. So if we talk about the HSV2, it's basically a sexually transmitted infection that cause genital herpes. So this area having a million, around estimated 417 million people between the age of 15 and 49, 11% worldwide have a HSV2 infection. Infection with HSV2 increase the risk of acquiring and transmitting HIV infection. So this is one of the major cause for the infection spreading of HIV through this HSV2. So if we talk about the HSV infection, then the initial infection with the retrograde transport HSV to the sensory nerve ganglia, then their sensory ganglions are involved, and then they have involvement of reactivations from laterally with the mucosal shedding and the lesion with the viral travel antegrade to the skin or the mucosa. So the HSV in the latent stage and then the nucleocapsid stage, you can see these are the two stages, and then they convert into enveloped herpes simplex virus. This is the cycle of herpes simplex virus. So the majority of these cases, 85% occurs during birth when the baby comes in contact with the infected genital secretion in the birth, and the 55% are infected in the utero, and 10% of cases are acquired after birth. So the detection and prevention is difficult because the transmission is asymptomatic in 60 to 98% of the cases. So that's why it's a challenge. So if you talk about the immunoglobulin response in herpes simplex infection, you can see that the IgM arrives approximately 7 days before IgG, and the IgM can reappear during recurrence. So you can see that the antibodies titers from the 0 day exposure to the 7 days. After the 7 days, that's when the value of IgM is increased, and then after that it increases, that IgM increases, and then after the 28 days, it goes. They have achieved the plateau between 21 to 28 days, and then it goes down, and then the IgM reappears during the recurrence as well. But the value for the IgM is in the lower range as compared to the first exposure. So if we talk about the IgG, the Ig has an later on stage increase after the 14 days of exposure, and then it goes up till the 28 days, and then after the 28 days, it's a plain value of a recurrence main value for that. So if we talk about the serological testing for HSV algorithm, that's the a pregnant woman who have an HSV1 and 2 type specific IgG testing. Then the HSV1 and 2 are negative, then they have to check the immune status of the partner, and then partner is HSV, then educate the couple having the potential risk of HSV2 infection and the production. So the pregnant woman is HSV1 IgG positive, then the partner is HSV2, then they educate the woman and her partner to avoid genital contact, use of condoms, and antiviral treatment is recommended. So if the HSV2 IgG is positive, then they educate the woman and her partner antiviral treatment, consider avoiding vaginal delivery, and then the HSV1 and 2 IgM is positive, and HSV1 and 2 IgG is positive or negative, it's an active or recent infection. If the HSV1 and 2 IgM is negative and the HSV1 and 2 IgG is positive, it shows the previous infection. But if the both are negative, there's no herpes simplex virus infection, because there's no HCV antibodies have been produced yet. So if we talk about the summary for the toxo, rubella, cytomegalovirus, and herpes, including the others infections, they have a pathogens like toxo, rubella, CMV, and HSV. IgG positive rate, if the less than is 80%, 80 to 95%, 60 to 90%, 80 to 90%, 20 to 30% on the basis of HSV1 and 2. The IgM positive rate is 6.6% to 20%, 0.22%, 7.7 to 10.5%, and 0.5 to 1.5%. They have a higher risk period in the first trimester, while the HSV is the perinatal period is most important. If we talk about the abortion and tetragenic rate, if the toxo IgG positive rate, or they have some cases they are 30%, and in case of rubella, abortion or tetragenic rate is 20 to 60%. In case of cytomegalovirus, the tetragenic rate or abortion rate is 50%. So for the HSV, that's in 50% stillbirth or neonatal mortality is observed in these cases. So if we talk about the part 3, which contains the Maglone solution from the SNIPE platform. So this is about the SNIPE solution. So we have very comprehensive torch, IgG, IgM, IgG, IgM, IgG, IgM, HSV1, 2 IgG, HSV1, 2 IgM, HSV2 IgG, HSV2 IgM, HSV1 IgG, HSV1 IgM. So this is the difference between HSV1 and 2. If the patient or a physician need a specific antibodies, either IgG or IgM, for 1 or 2 differentials, so we have launched these 4 parameters, 1, 2, 3, 4. They are launched as of today. They have available with the HSV1, 2, IgG and IgM assays available, while the other competitors, if we talk about Roche, Abbott, Siemens, and the Beckman, they have a missing part of HSV1 and 2 IgG and IgM. If we talk about the Abbott, they have a very missing part of herpes simplex virus, while the Siemens, they have also has scattered the torch menu on that. Like they have HSV1 and 2 in Imulite, HSV2 on Atlica, HSV1 IgG on Atlica, and they have a scattered menu on different instrument platform. So that's not an ideal situation for a comprehensive menu for the torch profile. If you talk about the disorin, their missing part is HSV2 IgM and HSV1 IgM. These two assays are still missing from the disorin platform. We have a very comprehensive solution for the torch from one window. It's a really very comprehensive as compared to the other competitor in the market. So if we talk about the Magluni Toxo 1, we have Toxo IgG and IgM kit. You can see any question if you have, you can ask. I'm going fast. You can hold me to have a slow pace. If you are okay, then I can continue. Any question if you want? Okay. Okay. So if we talk about the Toxo IgM and IgG, we are using a sandwich principle for the detection of antibodies for toxo. The sample volume is just 10 microliter is aspiration volume. We have a traceability for IgM is the internal reference substrate from a material from the SNIBE, while for the toxo IgG, we have a WHO plus international standard material 01/600. So the reference ranges that's in the non-reactive, less than 2 AU per ml. The gray zone is between 2 to 2.6, and the reactive is greater than 2.6. If we talk about the IgG, that's in a non-reactive is less than 2, and reactive is greater than 2. So these are the results interpretation for the Toxo 1. So if we talk about the rubella, we have a rubella also based on the sandwich principle. Just a 10 microliter sample volume is required for IgM and IgG separately. We have internal reference material for the IgM rubella standardization and the traceability. While for the rubella IgG, we have a standard WHO first international standard Ruby-1-94 material format. If we talk about the reference ranges, they have three types of reference ranges for the IgM. That's the non-reactive, gray zone, then the reactive. Less than 2 is considered as reactive. Greater than 3 is considered as, less than 2 is considered as non-reactive. Greater than 3 is considered as reactive. The gray zone between 2 to 3 is AU per ml is considered as a gray zone. If we talk about the rubella IgG, they have a non-reactive and reactive interpretation in the reference on the basis of the reference ranges. They have a less than 2 is considered as a non-reactive, and the greater than 2 is considered as a reactive. So if we talk about the CMV IgG and IgM, they have also a sandwich principle, 10 microliter, it's now internal reference substrate for the IgG and IgM, and their normal non-reactive and reactive value is less than 2 and 4.2. So the gray zone for the IgM is between 2 to 4.2 AU per ml, while the IgG has a non-reactive and reactive interpretation on the basis of less than 2 and greater than 2 AU per ml. So if we talk about the herpes simplex virus, so HSV1, we have HSV1 IgG, HSV2 IgG, HSV1 and 2 IgM, HSV1 and 2 IgG. So all these assays for herpes simplex virus, either the 1 IgG and 2 IgG or 1, 2 IgM or 1, 2 IgG, they're all based on the sandwich principles. So we have a 10 microliter aspirating volume, and we have a SNIBE internal reference substrate for these herpes simplex virus, 1 and 2 IgG and 1 and 2 IgG and IgM combinedly. So if we talk about the reference range for the HSV1 IgG, reference range is less than 0.8 and reactive is greater than 1.0. For the non-reactive IgG, HSV2 is less than 2 and greater than 2. If we talk about the IgM antibodies, they have a non-reactive, gray zone, and the reactive is less than 2, between 2 to 4 and greater than 4 AU per ml respectively. So if we talk about the IgG for combine both HSV1 and 2, there's a non-reactive less than 2 AU per ml, and for the reactive is greater than 2 AU per ml. So if we go to the HSV second generation, this is first HSV 1 and 2 IgG, HSV 1 and 2 IgM, HSV 1 IgG, HSV 2 IgG. Their principle is the indirect chemiluminescence immunoassay, and this is a qualitative assay. The sample volume is 10. The SNIPE has internal reference material for that. Their cutoff is 2.0 AU per ml. Now, the gray zone is between 2 to 4 AU per ml, and the gray zone is also 0.8 to AU per ml for IgG. So, if we talk about the HSP2 IgG, the cutoff value is less than 2 AU per ml. For the IgG, they both have 1 and 2, and 2 have less than 2 AU per ml cutoff, while for the HSV1 and 2 IgM and HSV1 IgG, they have a gray zone value between 2 to 4 or 0.8 to 1. So if we go for further question answers for the torch screening, we have why should test the IgG and IgM simultaneously? So the IgG and IgM test should be done at the same time. If the doctor only refer to IgM results, he may be give a wrong diagnosis. IgM positive cannot fully indicate the recent infection. IgM of some people after infection can exist for the several years, such as the rubella non-acute infection IgM. The reason can be divided into the following two conditions: either the IgM true positive or IgM false positive. In some people, IgM express persists for many years after the infection, and the IgM level is often kept low and stable and after accompanied by the IgG with the stable level. So the IgM result obtained by the kits are correct, but it does not mean that the individual is suffering from the acute infection. So this is also a possibility of IgM antibodies, especially in the rubella cases, are observed. They are positive, but they are not concluded as an acute infection after the confirmation of 2 to 3 weeks for the pregnant woman. In some cases, IgM false positive due to the influence of the factors such as the rheumatoid factors. They have a cross reaction with the polyclonal stimulation, and the error in the detection incident of the kit cannot be completely, which is also an inherent limitation of the immunological detection. So in some cases, the IgM false positive result due to the RA factors or some heterophilic antibodies or HAMA antibodies may also interfere in some assays. So they may lead to the IgM false positive result, but there is no clinical symptoms of the patient having a past or recurrent infection. So that's all about the torch profile. Let me check. Any question if you have? If you don't have a question, let me check to share with you some. Okay. Okay. Irina M, thank you. Let me check what I have something for you, especially when you are using the torch profile. Okay. Let me check if I have some my personal presentation on torch profile. Any information which you need to go for that? Okay. So So let's go for one more presentation and then we will take a break, right? So the next presentation is about kidney function. Just give me 1 minute, so I have to take one picture. Okay, so let's start with some presentation on the kidney function. So in this presentation, we have three parts. The first part contains about the introduction of the kidney functions test, and then the second part contains the clinical utilization of the renal function test, and then the SNIPE solution for the renal panel. So let's start with the introduction. So let's talk about the kidney. This is one of the vital organ of human body, and you can see that if we talk about the kidney anatomy, you can see that there's an outer layer, it is called a, fibrous capsule. Then the inner layer is called a renal cortex, and then renal medulla, the renal papilla, the renal pyramids are there, and the renal column have stems for the filtration. So basically, the major function of the kidney is the formation of urine. It's after that they have also some other part which include the minor calyx, the major calyx, and then this the tubular network is connected to the urethra, and the renal pelvis is also connected with the renal veins and the renal artery and the hilum. So the kidney, this is the overall kidney anatomy, and the major function, as you know, that this is the formation of the urine to filter the blood from the nitrogenous waste materials, and then can be excrete out from body to the different through the urine. So the another function of this kidney is also to secrete some hormone like erythropoietin, then EPO, and then calcitriol. This is an active form of vitamin D, the renin, etc. It also helps to regulate the blood pressure to maintain the renin and angiotensin systems, and it also keep the acid base balance, um, combining acting with the lung system. So if we talk about the regulation of the osmolality, it's also maintain the salt and water levels in the body, maintenance of that. So acid base balance, and along with that, the salt and water balance regulation of the osmolality is also controlled by this kidney. So if we talk further about the formation of the urine, you can see that in the urination process is there are four major steps. The one is called filtration, reabsorptions, secretions, and the excretions. So if we talk about the glomerular capillaries, which play a very vital role for the filtration, so this has an Bowman capsules, and they have in some peritubular capillaries and the renal vein that helps them to initiate the process of the filtration, reabsorption, secretions, and excretions. So the first filtration process occurs in that area of the Bowman capsules. You can see that they take place at the renal corpus, and then the glucose, uric acid, urea, water, sodium, potassium, chloride, and a small molecule like protein or beta-2 microglobulin or albumin are filtered from the blood to become initial urine. Then this second steps is peritubular capillaries, and then this Bowman capsule area reabsorption, and it takes place at the renal tubulars. Then the transportation of molecule from the initial urine into the peritubular capillary. Then most of the water, glucose, protein, beta 2 microglobulin, albumin, sodium, potassium, chloride will be reabsorbed. So here is the peritubular capillaries helps to start the process of reabsorption. And then in the third steps, this is the molecules are transported from the peritubular capillaries into the initial urine. So the unwanted material, the excessive materials, then transport into the initial urine. And then the excretion. This initial urine travel through urethra to become a final urine. So this is the excretion overall of the urine. Excretion is based on the filtration. Here the filtration is occurs, and then the next step is reabsorption, and after the reabsorption there is some secretions, and then secretions may lead to the urinary excretion cause. So this is the natural process of formation of urine. So if we talk about the clinical application, we have a beta 2 microglobulin from the immunoassay platform. So this is basically a seroglobulin which is produced by the lymphocytes, blood platelets, and polymorphonucleosols as a small molecule, and it's filtered through the renal corpuses. That's in 99.9% of beta 2 microglobulins are reabsorbed in renal tubules and decomposed in the renal tubular epithelial cells. Therefore, only the slight content exists in the urine. So the determination of beta 2 microglobulin can be used as an indicator of kidney filtration rate. So the autoimmune disease SLEs, rheumatoid arthritis, and malignant tumors like liver, lungs, colon cancers may lead to elevated serum beta 2 microglobulin. So these are the early marker for the such examples of carcinoma and some other diseases. So what are the high levels of serum beta 2 microglobulin and while urine beta 2 microglobulin within the normal range? So there are two levels of beta 2 microglobulin, one in the urine beta 2 microglobulin, and other is the sample beta 2 microglobulin. So for the nephrotic syndrome or a nephritis in a kidney failures, these are the normal renal corpus filtration rate and impaired renal corpuscles that may lead to the abnormally high level of serum beta 2 microglobulin, and with some in some cases they have a beta 2 microglobulin urine is normal range. So overall overview is about the nephrotic syndrome is that the collection of the symptoms due to the kidney damage. So the symptoms, that's the protein in the urine, the low blood albumin levels, and high blood lipid. So the this condition or nephrotic disorder may also due to the some chronic diabetes mellitus or also the reason for that, and the lupus disease also one of the leading cause for this nephrotic syndrome. If we talk about the nephritis, that's basically inflammation of the nephrons in the kidney. Then the overview is of the inflammation of the overall kidney, and the symptoms are the reduced urine output, and the blood appearing in the urine is also the early marker for the nephritis. And this is occurred due to the uremia, or there is some sudden stroke, or due to the prolonged proteinuria may lead to the nephritis. If we talk about the kidney failures, so overall, the kidneys are functioning at less than 15% of normal. The symptoms, leg swelling, vomiting, loss of appetite, the complication is maybe a uremia, the high blood potassium, the heart disease, and the anemias are the early markers for the kidney failures. So the high level of urine beta 2 microglobulin, that's a renal tubules reabsorption dysfunctions, is the major cause for the high level of urinary beta 2 microglobulin. So the kidney transplantation rejection for the crowd kidney failures, and the rejection symptoms high level of due to the urine beta 2 microglobulin. So this is the damaged kidney you can see here, and this is a kidney transplant. When the transplanted kidneys is there, that can be a solution. So if we talk about the albumin, it's basically a big molecular globulin product in the liver, and only the few albumin can be filtered in the renal corpuscles due to the big molecular weight, and the most of the albumin will be reabsorbed in the renal tubules. Therefore, only few albumin exist in the urine. Serum albumin determination can be used as an indicator of liver disease. Urine albumin determine can be used as an indicator of kidney functions as well. So if we talk about the elevated urine albumin levels, so the typical cause of elevated urine albumin is the atherosclerosis. In the adult patient, leading to increased renal corpus filtration rate, and the low-term hypertensive nephropathy implicates kidney. And the diabetes also one of the cause for that high elevated urine albuminuria because it's due to the nephropathy. So the other cause of elevated urinemia, the drugs toxicity, and maybe some dehydration leading to the hormone concentration, some chronic disease that may leads to the elevated glomerular systematic lupus erythematosus, and the multiple sclerosis are the one of the chronic disease that may lead to the increase in the global levels. So what is the solution which is provided by the SNIPE from the Meglumi platform? We will discuss in that part 3. So in this part, we have a beta-2 microglobulin, first generation and second generation. So the sample types in the first generation is the serum and urine, but in the beta-2 microglobulin second generation kit, we have a privilege of having a plasma, including the serum and urine samples type for that assay. We have a competitive quantitative analysis of beta-2 microglobulin. The dilute is also included for the high results value dilution. So the traceability with the WHO first standard of beta-2 microglobulin, our assay reliability showed that. The calibration frequency is 28 days in second generation, while the first generation it was 1 week. If you talk about the sample storage, urine sample cannot be frozen. That's a recommendation for the type 1 generation 1 beta-2 microglobulin. But in the beta-2 microglobulins second generation, the frozen specimen subject to up to the 1 freeze thaw cycle has been evaluated. So the evaluation based on the 1 freeze thaw of a urine sample can be used for the beta-2 microglobulin second generation. So if we have a sample volume is the 10 microliters as per rating volume, so you have to put 110 microliter for the Meglumi assay, so that can be ideal for the running of these parameters. So the expected value in the second generation and the first generation, between that, the serum is 0.9 to 2.7, while in the second generation is less than 2.1. For the urine is less than 0.195 microgram per ml. For the random urine is 0.15 microgram per ml. So the assay range is between 0.03 to 10, which is same in the second generation, but we have a edge of at least 2 level of QC verification free of cost from the beta-2 microglobulin second generation platform of the SNIPE Meglumi assays. So this is an edge we have in the second generation as compared to the first generation assay. So if we talk about the albumin, we have both first generation and second generation. In the second generation, we have 24-hour urine samples, or other time urine samples can be run. So these are usually the urine albumin samples are called microalbumin. So in the diagnostic industry, the urinary albumin is considered as urinary microalbumin. So this is a competitive assay and the quantitative assays. As include a diluent. Yes, dilute is included in the reagent. We have a traceability of internal reference standard in the albumin second generation, while that for the first generation, we have a ERMDA 470K/IFCC for IRMM. The calibration frequency was 7 days, but we have a second generation albumin has a 28 days onboard calibration stability. Here, the calibration frozen stamp specimens subjected to the 2 freeze thaw has been evaluated. Just 20 microliter sample is required. The expected value on the basis of excretion rate is less than 19.6 microgram per minute and less than 28.4 milligrams per 24 hours. So this albumin, especially the urinary microalbumin, either the spot urine or a 24-hour urine can be has a different expected value for 24 hours urine and the spot urine. So the assay range is between 2.50 to 480 microgram per ml. If the higher result is greater than 480, can be diluted because the dilute is included in the reagent of albumin to provide a patient exact results in case of nephrologists want to require the exact value. So in the second generation of albumin, we have a solution for quality standard, low and high, two levels we are offering, along with the reagent free of cost. So that can be checked the performance of the albumin assay at a lower and higher side of results. So if we talk about the 24-hour urine collection process, so I hope you know that how to collect a 24-hour urine. So in the morning, you have to discard the first urine sample. And then you have to take the urine sample after the first urine discard. And the rest of the day, you have to collect the urine in the same container for the next 24 hours. It means like if you have decided to collect a 24-hour urine, in the morning, you have to discard the first urine samples. And after that, all urine samples should be received in a container, should be collected in a container until the next morning first urine sample. So these urine samples are collected at the same time on the morning of the second day, and the total 24 hours urine volume to be measured was recorded. So then you have to deliver that urine samples to the laboratory, and the laboratory personnel they can measure the volume and take the sample in a tube. And after collecting the urine, it is thoroughly mixed. They have 5 to 10 ml of urine is taken for the detection. So there's a calculation formula for 3 hours urine albumin, that's in a mass, that's a microgram, and the instrument test results, you have to multiply by 3-hour urine volumes, or if they want to calculate or on the basis of 24-hour urine collection, they have the value of the test of the albumin from the instrument, then they have to multiply the 24-hour urine volume. So that's the way that they can calculate the formula. So the precaution of the urine collection. Do not drink too much water before collecting urine. This is the generalized instruction to the patient who are given a 24-hour urine. They have to avoid using any of form of adrenal corticosteroid, topical ointment, urinary retention, or before collecting urine samples. So the collection container need to be disinfected and placed in a cool place to avoid any direct sunlight. So if the experiment is completed within 8 hours, the urine sample can be stored at 2 to 8 degree centigrade temporarily, and the urine sample cannot contain the air bubbles. If the urine sample contains particulates, impurity, they must be centrifugal before testing. So the SNIBE has a solution from the McLuhan platform for the renal function or a kidney function is beta-2 microglobulin, albumin, and the NGAL. So the SNIBE McLuhan has also providing an NGAL from that platform. While the other companies like Roche, they do not have these two analytes, and they have neither the renal function of NGOL. The Abbott Architect has a NGOL. The LRT has underdeveloped, and the Siemens Advia, Centaur, Atlica, Emulite, and the Beckman Unicells, Vidas, and Lyson. Only the Emulite has a beta-2 microglobulin albumin, while the Biomirics Vidas has a beta-2 microglobulin. So these are the analytes which are comprehensively available from the SNIPE platform. If we compare the commercially available beta-2 microglobulin with the SNIPE McLuhan beta-2 microglobulin first generation assays, that we have a regression value of 0.98 on the basis of the SNIPE comparison with the commercially available beta-2 microglobulin, which shows the excellent correlation in terms of microgram per ml unit with the other competitors in the market available. So if you go for albumin first generation, that you can see that there's a comparison of commercially available albumin assay with the SNIPE McLuhan albumin assay using the clinical samples and a regression value of 0.95, which also shows an excellent correlation with the other competitor in the market. So this is all about that. And let me check with you if the patient is given a urine sample for microalbumin, what are the preservatives? Let me just give me a 1 minute so I can share with you one chart with helps you a lot for the uh, selection of. Let me check. That's so. Mileage, glucose, microalbumin. Okay, let me share with you one extra information. If you are interested, you can see here. You can see here. Let me share with you. Mhm. So you can see here for the beta 2 microglobulin, the 24-hour urine samples preservative is pH. You have to check the pH between 5.5 to 7.5 by adding alkali. So for the random urine, it's also have to maintain the pH of 5.5 to 7.5 by making adding alkali, right? For if you want to go for a further microalbumin, because in the urine there's a microalbumin. Where is the microalbumin? So you can see here. So the microalbumin, the preservative for the 24-hour urine specimen is the 6N-HCl or acetic acid or a chloroform or formalin, toluene or xylene is recommended. So even for the random sample is also recommended. Yeah, it's not CLIA, but the urine preservatives are for the analyte degradation prevention, right? This is for the chemistry. I agree with you, but the thing is, what preservative we can use for keeping the analyte like microalbumin in that. So you are right in chemistry, but the preservatives for them are globally recommended. But it's if they want to store or they want to keep the specimen with this microalbumin for the 24 hours collection, then they can use the 6 normality HCl in it for the preservative, right? This is my perception. Uh, Anton K, in my opinion, either you check through the chemistry analyzers or check through the immunoassay analyzers. You need to preserve the target molecule like microalbumin or beta microalbumin. So this preservative is for preserving the target molecule, right? To retain that. But let me check one more time that if they have we have any other recommendation. But in generally, this is all across the board. Like for the chemistry or immuno, the preservatives are same, right? So any other question if you have? Okay, just give me a one more second, then I have to check one more thing. Just give me a one more second. That's important is about beta 2 microglobulin, right? Just give me a 1 minute. I have to go to hmm, I have to go to YouTube. Hmm. So So this is the package insert for the beta 2 microglobulin. Let me check any preservative they have recommended in that. Urine. Okay. Collect the urine sample using standard procedures. Urine cannot be frozen stable for up to 4 days at 2 to 8 degrees centigrade. Stored sample should be thoroughly mixed prior to use. All the sample. So if you see the collect urine sample using, so they are in the package insert, they are recommending you to test within 3 hours. But if you want to store the urine for more than 3 hours, so you need to use the preservative. In my opinion, if someone is doing a urinary beta 2 microglobulin, they have to collect the samples. And after a 24-hour sample collection, they separate the one sample without preservative, and in the second sample, they put some preservative, and they have to check the value of beta 2 microglobulin after 48 or 72 hours. If the beta 2 microglobulin remain stable in a tube with the preservative, it means that the preservative stabilize the beta 2 microglobulin value in that tube, because the urine is a one source of infection. They have different bacteria inside the urine samples, and then they may leads to the biodegradation of the beta 2 microglobulin. That's why you have to keep either the urine acidic in nature or alkaline in nature to prevent any bacterial or growth for that. So it's need an experiment, but in this package insert, I have no idea. I have no idea about that. So you need to do an experiment. Anton K, you need to do one experiment. If the customer is using any beta 2 microglobulin urine sample, if they have a 24-hour samples, they have to go for a 24-hour sample with one without preservative, and the other sample they can put some preservative, right? And then through the testing after 48 to 72 hours of those both samples, help them to that, because usually these beta 2 microglobulin, then the urinary microalbumins, they are done by the photometry, and then they are used as a preservative. That's so the preservatives are universal. So you have to be make sure that these there is no interference which occurs in urine samples, right? But here in the package insert, they simply recommend you to not to freeze, and up to the 4 days at 2 to 8 degrees centigrade is stable. And after 4 days, the stability of urinary microalbumin without preservative is not guaranteed. That's the recommendation in the package insert, right? So no, if we talk about the urinary albumin, let me check the albumin as well. Let me check here. In human urine, so if they have also a urine, random urine cannot be frozen using standard procedures. Discard the first urine, drink about 1.5 after starting the timekeeping, 3 hours. Stop collecting of the urine. Instead of okay, they are giving without any preservative the stability of urine sample for urinary microalbumin, and then a beta 2 microglobulin is 2 to 8 degrees centigrade up to the 4 days. But if you want to keep the samples beyond 4 days, there is no preservative is validated in our package inserts. For the best purpose is either you can evaluate, or you can want to follow the maximum 4 days stability of analytes at 2 to 8 degrees centigrades. That's the recommendation. But if I have got an opportunity to a customer who is using microalbumin or beta 2 microglobulin, I will try these preservative, because these analytes are usually from the other company's platform. They are from the chemistry principle, but it doesn't mean that the preservative may have impact on the chemoluminescence. That need to be validated, and it's either I have to recommend it to the SNIBE headquarter. They need to evaluate the specimen preservative, especially for the 24-hour urine, because the collection of 24-hour urine sample is tedious. Or if they want to retain that sample for more than 1 week, what are the preservative recommended by, or is they validated by preservative are not having an impact in the chemolysis? Your question is very logical, and right now I have no idea about that. That's impacted, but we need to verify that. So this is all about the renal function. If you have any question, you can ask. Otherwise, we have to go for a 15 minutes break. Okay, so let's go for a 15 minutes break. Thank you.